Hey, good morning and welcome to the UroPatient podcast. I'm your host, Vic Senese. Glad to have you on board. If you're watching us live, you can watch us on Facebook, LinkedIn, X, what am I forgetting? YouTube and Kick. All of those are coming to you live at the same time every Saturday morning at 10:30 a.m. Central Time. If this is your first time checking us out, be sure to go to our website at UroPatient.com, the best place to learn more about us. That's the best place to see more information and all of our past episodes. Boy, we got a bunch of them. So check out all of those past episodes for something you might have missed. Also, we've got these helpful information handouts that I put together. You can go there free of charge. Just copy them and take them with you to your doctor's appointment or just have them as a reference. They're yours. Go ahead and get those. Hey, we've got a great episode for you today. Be sure to always join us every week. And here we go. Today, we're diving into one of the most exciting advances in prostate cancer treatment, the NanoKnife. I'll explain what it is, how it works, and what it means for patients facing prostate cancer. Prostate cancer affects millions of men globally. While traditional treatments like surgery and radiation are effective, they can come with significant side effects. Today, we're going to discuss how the NanoKnife can offer a less invasive alternative. The NanoKnife uses a process called Irreversible Electroporation. Essentially, it delivers controlled electrical pulses to destroy cancer cells while sparing surrounding tissues, which is a big advantage over traditional surgery or radiation. Imagine it like opening tiny holes in the cancer cells until they can no longer survive. The beauty is that healthy tissues around the tumor, including nerves that control urinary and sexual function, are preserved. Patients often go home the same day, and the procedure is precise thanks to imaging guidance. Recovery is typically much faster than traditional surgery, and side effects are often less severe. So I thought I'd start off with a little demo that the company puts out about their NanoKnife. That's the position that a patient is put in. That orange is the prostate. And this is so that a probe can be placed inside the rectum that will then use ultrasound to show where the needles are being placed. And this grid device shows exactly where the needles are going to sit. It holds them precisely in place. And there we can see the ultrasound view so the tumor can be placed right into those needles. Then electricity is turned on, and it precisely destroys just the prostate tumor with those electrical pulses, destroying the actual tumor cells. And that's how it works. Now I'm going to play an excerpt from an interview I did with Jake Brumbaugh, the VP of Marketing for the maker of NanoKnife, and Dr. Preston Sprinkle, a urologic oncologist from Yale, where they discussed further about the procedure, and I thought it might just be best to bring in the experts. Focal therapy is not a new concept. It's been around for, at least I think 20 years ago, one of the Reiki guys was talking about why do we, radiate the whole prostate when we can really concentrate it on what's showing up as positive. So how does this differ from like some of those other focal therapies? And maybe Dr. Sprinkle, maybe you want to take that one?
Sure. So, I think, yes, the concept of this has been around for a very long time, and the desire for a targeted therapy in prostate cancer, the desire has existed. The issue, and Jake mentioned this a little bit, but it was really the revolution in imaging in around 2010, 2012, when we began using MRI for the prostate more concertedly. And that allowed us, that was really the first time we were able to look into the prostate and evaluate for that index lesion, evaluate for tumors and be able to see where they were. Prior to that, people were doing ablation therapies, but typically they were whole prostate or whole gland therapies because we just weren't confident that we knew where the cancers were. And as Jake mentioned, the disease, when we did remove the prostate, we found that cancer was multifocal. So there kind of been a few different things that have evolved over the last decade, 15 years. Imaging to see where lesions are, a better understanding that when we do targeted biopsies of these visible lesions, that sort of index theory developed from that, where we are seeing true biologic importance of imaging visible cancers. And then we've also gained more understanding of what is cancer that needs to be treated. So low risk cancers don't need to be treated. Intermediate and higher often do. And we can provide those targeted therapies. Like the index lesion is what's important because the low grade cancers are not. Treating them isn't going to change someone's cancer outcome. So you kind of asked, well, so, what is IRE? What is NanoKnife? It's actually been around for a while in prostate. I mean, I personally have been using it for almost 10 years now. We did have a lot of insurance challenges, so we didn't use it as much as some of the other technologies. But it is one of sort of, a handful of technologies that are very effective in providing this sort of targeted therapy. And as Jake highlighted nicely, we're starting to get a better understanding and, I guess, crowd swell a little bit of people asking for this. And that's really what is driving it so far. The evidence now is getting significantly better, and we hope to see some changes in the guidelines because that's what drives insurance reimbursement, quite honestly. Doing a lot of discussions with the insurers are like, well, until it's in the guidelines, we're going to keep giving people a hard time for this. So I think we're getting enough data now to show relatively equivalent success rates in terms of cancer control with things like surgery and radiation. We're seeing much lower rates of side effects. So again, not zero side effects, but the on average sort of impact on sexual function, impact on urinary function does on average seem a lot lower with the subtotal therapies than you get with a whole prostate treatment. So it's an exciting time.
So you and Jake both mentioned this term index lesion. Can you go into a little bit more about what that is? Is this an MRI sighting or explain that if you would?
Sure. So what we've seemed to figure out, and this is continuing to evolve, but often about 80% of the time when we are evaluating a man's prostate with an MRI, there will be one lesion that's larger. And when we do targeted biopsies and biopsies of the whole prostate as well, we find that 80% of the time there is really one area that has the highest grade and highest volume cancer. And studies have been done to show that the genetic components or the genetic signature of those cancer genomic signature are of that index lesion. That is really where metastases come from. So by targeting and treating that index lesion, so the clinical pathway, someone comes in with an elevated PSA, they get an MRI of their prostate. If we see one area or the highest risk area, we can target that with biopsies, confirm that cancer is present there, but then treating that lesion, again, and more than probably about 80% of men will have this one area that is the high risk cancer. So ablation or a subtotal therapy is not appropriate for everyone, but almost 80% of prostate cancers will conform with that.
Yeah, thank you. That's a nice explanation. And then we do have a question that came in. So who is the ideal candidate then for NanoKnife therapy? Whoever wants to take that one.
I'll let the physician take that one. Yeah, I'll let you take that.
So from a clinical perspective, I think the men so a NanoKnife can be deployed pretty much anywhere within the prostate. So it is one of the ablation therapies that is really very effective no matter where you use it. So as Jake kind of mentioned, we can treat near the urethra. We can treat near the peripheral zone, near the nerve bundles. Because it has a precise margin of treatment, we can control that area quite well. So someone who's a good candidate would be someone with a prostate cancer that is localized to a relatively small area. Jake, you may know the numbers. I don't recall off the top of my head, but it's about, from a size perspective, we can treat up to 3 centimeters by 3.
Yeah, 3. So I'd agree. So about 3 centimeters by 3 centimeters.
Our maximal treatment area, about 9 cc.
Yeah. And, I think the only thing I'd add in is, I guess what I was passing over is for focal therapy or for the candidates for the NanoKnife system, really anyone that qualifies for focal therapy, first off, based on how that physician kind of stages and grades patients, are going to qualify for this. Where the NanoKnife does come into play is, one, we're not contraindicated from calcifications. The size of the prostate is not limiting. It's relatively versatile. So normally when someone asks, hey, who's an ideal candidate or qualifying, it really is just those patients that best qualify for a focal therapy procedure, have the physician that feels well equipped to explain it to them, and options up for that. But there's no other limiting kind of features around the NanoKnife system beyond just qualifying from a focal therapy perspective.
Which is more of a discussion to kind of understand what that means. I mean, it's not easy or really appropriate for someone who needs a whole prostate treatment. I mean, there are some whole prostate ablation technologies that we can utilize to treat the whole prostate, but that's IRE or NanoKnife would not be my first choice in those situations.
Okay. Another question, what kind of recovery time can patients expect compared to more invasive procedures? What kind of recovery period?
Yeah, that's a great question. I think that's one of the things that differentiates the ablation procedures. So for surgery, typically it's a 4 to 6 week recovery just because of the incisions. It takes a while to heal and get back to full activity. With radiation therapy, depending on the intervention, it can be either treatment over 10 days or treatment over 6.5 weeks to even sometimes 9 weeks. And those are typically daily treatments, 5 days a week or so for some of them. So you're looking at a month and a half really for treatment and recovery. And even with the short interval of radiation therapy, there still is some fatigue and recovery after that for a couple months. With the ablation therapies, pretty much all of them are same day outpatient procedures. So you can have general anesthesia. You could have even some groups do it with spinal anesthesia in an outpatient clinic, not NanoKnife, but some other technologies like cryoablation or HIFU. But patients
NanoKnife is done under what anesthesia then?
General anesthesia, because it uses electricity, it can cause activation of the muscles in the pelvis. So we need people to be asleep for that and paralyzed. But we often do that anyway for many of the other ablation technologies that we use. But in general, in terms of the recovery, it's go home the same day. I personally leave a catheter for a week because I think that minimizes concerns with urinary retention. A lot of men are very concerned about a catheter. I can tell you it is annoying and a change. It is really very bearable, and having it in for a week is much better than having it out earlier and not being able to urinate and having the discomfort of being in urinary retention and then having to have a catheter replaced while you're awake. But after that week of a catheter, most men are able, 95% of men are able to return to their normal activities sort of in that week. And they often feel better than that even before the catheter comes out. But I think that is one of the major things. We often hear reported cancer outcomes and continence rates and sexual function. And while those things are true, that happens over months to a year that we find that. But, the actual recovery from the procedure and the intervention itself is much faster with ablation therapies.
That's what most patients are worried about. What am I going to have to deal with?
Yeah.
You're looking at all these therapies.
Yeah.
So I think we did kind of answer this one, only one treatment and how many treatments needed. So it's one and done, right?
Correct.
Right. And one of the defining factors I'd add there is so obviously the goal is capture large enough margin, single treatment, and obviously the physician will do the proper imaging and follow up to make sure that takes place. One difference that we think about when we think about focal therapy, especially the NanoKnife system versus radical, is you do have the potential option for repeat treatments. So, I think we had some clinical research done, came out of Australia, but at 5 years, about 86% of patients didn't need a further retreat. But there is a group of patients that will either progress to either a repeat NanoKnife, or they might progress to a radical surgery, or they might progress to radiation. And so the one thing that is not often talked about, because obviously you want it to work great the first time and do all that, but one thing that has been powerful in our experience when talking with our patients is the fact that we have a lot of clinical literature that shows how tolerated some of these definitive therapies are after NanoKnife. So NanoKnife actually does not take future options off the table, whether it be the repeatability of NanoKnife or whether it be a definitive therapy. So on average, yes, one and done. But if there ever is a need to progress down the treatment chain, it's not like it removes your ability to have a definitive therapy in the future.
Great. And then we did have a follow-up to that. Any side effects? So you had mentioned urinary retention, leaving a catheter in. My question is, would they be a candidate if they wanted to learn self-catheterization? And could they go home without a catheter then? And then any other side effects you guys want to talk about?
Yeah, it's a really good, that is a really good subtle point. I personally try very hard to avoid intermittent catheterization. So I know some patients would be interested in that. Really, until after 6 to even 8 weeks, I would not recommend intermittent catheterization. The biggest risk is infection and causing infection, either a urinary tract infection or infection in the prostate. That really is what's going to lead to something like a fistula, like a really terrible complication, or major kind of pelvic damage, because there's going to be necrotic tissue. There's going to be dead prostate tissue there that needs to be reabsorbed and healed. So you do not want to get that infected. So I very strongly recommend against and will not do or allow my patients to do intermittent catheterization for at least a couple months. And typically anyone who is in retention, we've had a small percentage, but anyone who's been in retention has resolved by 6 weeks post procedure. So even if there is a prolonged catheter, it resolves by 6 weeks.
Yeah, that's great. And any other side effects that you're seeing? You know, risk of infection, you said would be one. So urinary retention.
Yeah, so I mean, the main ones we see most commonly are urinary retention. There can be, depending on the treatment zone, or very often I tell everyone you're going to have some decrease in your erectile function for a short period of time. I think that just relates to any intervention we're doing on the prostate. But especially if it's near the nerve bundles, there's going to be a decrease in the ability to get an erection. There is going to be a decrease in ejaculate volume. So semen volume is going to decrease. Anything you do the prostate is going to decrease that. And ablation therapies are no different. You still may have some, I think with surgery and radiation, it goes away pretty much completely. With ablation therapies, you may have some ejaculate, but I wouldn't count on it. Urinary incontinence is more theoretical. I think, it can happen. In the PRESERVE trial, there was a small percentage of patients that seem to have some incontinence. Most often, I actually find that incontinence is not stress incontinence. It's not the kind that we associate with surgery. It's actually urge incontinence. People have a little bit more urgency,
irritation.
And so I do see some kind of increase in patients' urgency in that sort of 2 months after treatment. There can be some really symptoms of frequency, urgency, maybe even some dysuria. We'll evaluate, make sure there's not a urinary tract infection. But most often there's not. It's just the bladder healing and the prostate healing and kind of around the bladder neck. And so that can definitely occur. Those are really the main things. I mean, theoretically, haven't seen it much, but there can be some urethral sloughing, sort of some of that necrotic tissue can drop into the prostate and cause some blockage, but that seems to be quite rare.
What about your experience with, just a little bit of bleeding, pain from the needle placement, et cetera, just the overall comfort after the procedure?
Yeah, no, you're right. It's easy to kind of gloss over that, but there definitely can be some scrotal swelling, and there can be some hematoma in the perineum and in the scrotum, which I forget as a medical professional is really not normal, and people really freak out about that, understandably. But you can definitely get some scrotal edema and a scrotal hematoma, sort of an eggplant kind of looking scrotum, which can be very annoying or concerning. So we talk about that a lot too in the prep sessions.
All right, great. We do have another question that just came in. Patients can have a chance for TPR after NanoKnife. I think it's TURP they were thinking of after NanoKnife. So other procedures are still on the market or on the table.
Yes. Yep. So after NanoKnife and really any of the ablation therapies, it doesn't preclude you from other treatments. I think that's one of the great things about these ablation approaches. I tell patients that, this is, while it's still very effective, with 80% to 86%, as was in Stricker's paper, effectiveness and able to avoid additional treatments, this is the impact, as you were talking about, like you're home the same day, less impact on urinary and sexual function. Like this is something that we very easily can repeat multiple times. And the cumulative, and we're not really actually seeing cumulative negative impact on quality of life factors. I mean, it could potentially, if you had disease on one side than the other, and it causes damage to the nerve bundles. But if we're treating sort of the same area, the same cancer, there aren't really sort of stacking or cumulative side effects that we've seen so far when we needed to retreat people, which is, so we have that opportunity. We're not preventing surgery for radical prostatectomy. We're not preventing radiation. We're not preventing TURP if someone does have retention and needs that. Although very often for patients with significant urinary symptoms, they actually on average tend to get better because we're removing and reducing some of the prostate tissue. So we actually see most people's IPSS or AUA symptom score actually improves on average with most of these ablation therapies.
Yeah, makes sense.
And the only thing I'd add into that as well is, sometimes, patients will undergo these procedures, and as Dr. Sprinkle said, especially several weeks later, you feel back to normal, right? If for any reason patients do undergo other procedures or need other procedures, et cetera, such as like a TURP, make sure you are telling your physicians that you did have a focal therapy procedure beforehand. I think sometimes it kind of slips their mind, and you definitely don't want a TURP right after a NanoKnife or any other type of focal procedure. And so I think that's one thing to call out is it's still an invasive procedure, that you still want to give yourself enough space for. It's definitely not like something you want to pair right alongside it. But, that's just a quick call out.
And I do just want to voice some caution. I mean, I am obviously a big proponent of these ablation therapies. I'm very supportive of them. I think that they are a significant benefit as an option for patients, but they are not without the possibility of side effects. So these are not free. There's not like we're treating the cancer and you're going to have no side effects. Like that is not the case. I don't want to try to give that impression.
Yeah.
The risks on average and the percentage of people that suffer from complications are lower than the whole prostate treatments, but they are not zero. So this is not a free ride. There still definitely can be changes in functional outcomes, and it's less than you would experience, but I always caution patients not to expect it to be no impact.
Mm-hmm. With that, are there any long-term outcome studies on patients treated with NanoKnife? What's the longest study you have out there? What's the progression-free disease rate?
Yeah, it's a great question, and it's one that we've been really excited about. So as I think I mentioned earlier, we have about 30 publications out that covers probably more than 2,000 patients. The longest study we have right now is a 5-year median out of Australia, and the longest patients on those studies are 8 years. And so developing long-term data is definitely something that AngioDynamics is passionate about. So, we know we have some data that reflects about an 8-year. We're currently working with some physicians around some other experiences and might be able to pull out around a 7-year, but our median outcome is right around 5 years, which is kind of similar. I think you're either looking at between 5 to 10 years for different focal therapy modalities, wherever you are. So the improvement of long-term follow-up, understanding that, I think that's something that us as a industry and AngioDynamics are really dedicated to, and it's something we're going to kind of continue to really focus on. In fact, we are actually extending our preserved follow-up to continue to collect data from these patients and make sure we're developing and keeping that long-term data. So short answer, 5 to 8 years, or 8 years, 5 years median.
And what was the progression-free rate then at
so
the 5 years?
That 5 year is what we were citing. The 86% of patients did not need a retreat, need a new NanoKnife or progressive retreatment. But, that is it's a prolific site, a lot of patients, but it is a single center experience. So,
yeah. Oh, great. I do have a couple more here. What are some of the common misconceptions about NanoKnife that you'd like to clear up?
Great question. Interesting. I think for the longest time, NanoKnife has a very unique mechanism of action. As I said, when you look at, let's say you go into your kitchen, I think everyone is familiar with freezing something, burning something, or cutting something. And so I think for a lot of physicians, it's very clear and very able to understand how a technology or how an energy source can destroy tissue. I think for the NanoKnife system, it works in a very unique way. Essentially, it's not killing cells. It's just putting holes in the cellular membrane, which eventually lead to a cell death. And so I think just the misconception that I'd like to clear up is just really nailing down that mechanism of action, how it leads to those holes forming in the lipid bilayer, and how that actually enables it to have a very consistent effect across the entire voltage area. You know, when it comes to some other technologies and stuff, as you move away from a center area, so if like it's really cold in the center and it starts to get less cold near the edges, with IRE, you really don't get that. And so I think it's more just clarifying exactly what that mechanism of action is and how different it really is to anything else people experience in the real world.
Yeah, great. You have anything to add to that, Dr. Sprenkle?
I don't. I mean, I think, you know, the IRE and NanoKnife is a very exciting technology. You know, there are patients who ask about it thinking that it's going to, you know, treat all of their cancer and sort of is going to seek out the cancer cells and treat it. I mean, I think that that is possibly a misconception. It does still remain sort of a treatment of a volume or area of tissue. It is not prostate cancer cell specific. We do not have any cancer smart bombs at this point. Like that, you know, that technology does not yet exist. It'll be great if we can figure that out, but it does not exist. So we still have to treat an area. We are always estimating where the cancer is. We cannot see all of your cancer. We see an area on the MRI where we think that it is. We confirm that by taking biopsy samples. We know that the MRI undersizes the amount of actual cancer that's in there from comparing MRI to prostate specimens. We've gained information about how much of an increased margin we probably need to take from where we see the lesion. There are actually some cool AI companies that are integrating the MRI, the biopsy information, and the ultrasound image to make heat maps of the extent of the cancer and how much area we need to treat. So I think that's an exciting area for the future. But, you know, nothing right now, like for all the amazing advantages and advances that we have, we still have a long ways to go. So we are treating an area of the prostate. It's not a smart bomb. There still is a risk that it can come back. There still can be damage to some of the nerve tissue, to some of the normal tissue. So while this is kind of close to the best that we can do, it still is very far from perfect.
Yeah. So kind of when I started UroNurse, one of the things that I really was an unexpected event was finding out about all these little things that are out there for treatments that I didn't know about. And, you know, and I've been in practice for 40 years, and prostate cancer therapy is just like boomed over the past decade. I mean, it's almost, I think it's difficult for patients to really make a choice now. There's so many choices out there. You know, when you kind of weigh them, what do you where do you tell patients? You know, you could have this, or this, and you know, hopefully there's more guidance that's provided by you as a doctor. But I think that, you know, patients are reaching out to places like me on the internet to find out more information, and I think it's going to be really confusing for patients with all these choices. So it's good and bad.
It is. Yep. No, I agree with you. I think it can be very confusing. We're very fortunate at Yale to have a variety of treatment options. So, you know, I feel very lucky to be able to offer multiple different ablation treatments to patients, so we can try to really personalize their care. In addition to, you know, using one technology in a variety of ways, we kind of have a variety of technologies that we can use in a variety of ways. So I think I saw as one of the comments, you know, it's great to have a full tool belt.
Exactly.
You know, the only thing I'd kind of add in there is, you know, when you think about BPH or something like that, they have a ton of different treatments. And I don't really think that, you know, it drives too much confusion or challenges for patients. In fact, I think, you know, over time, the patients have a better understanding of, you know, are able to kind of navigate that alongside their physicians. I think one of the things is, I think for people in the know and people that are at academic institutions and someone like yourself that's often, you know, evolved on the cutting edge of technology, Vic, when you look at the actual adoption rate of focal therapy and you think about the broader swaths of the country, the areas that maybe aren't near the academic centers, the areas that maybe have, service maybe a lower health IQ set of patients, or, much more transient in nature, they really still don't have access to those different pieces of that information. So while it can feel exciting and like there's a lot of new technology coming out, the reason I wanted to highlight that number is I think in our community, we're definitely becoming more aware, but definitely in the majority of the US and the everyday shared experience of a patient, focal therapy is not something that is often being discussed. And so I think that is one of those interesting dynamics where I think it's becoming this really interesting topic in a small subset of the population, so it feels like everyone's learning about it. And so with that time, as we kind of expand and hopefully make our way more towards that community of care, we'll get better at communicating and sharing that. And I hopefully think it'll end up just very similar to a BPH type dynamic where, there's a lot of treatment options, a lot of different ways that patients qualify, and, you just work through it with the patient.
Yeah. So my wife was helping me to organize my workbench downstairs. She's going through my screwdrivers, and she looks at it, she says, "What's this one for?" I said, "That's a standard screw. This one's a Phillips screw. This one's a star screw. This one's a torque screw." She says, "Why do you have so many for all these screws, these different bits?" I said, "Because they all do the same thing. Really, they do. But one has an advantage over another for different jobs." So I think that's the same thing here. So, well, I hope you enjoyed that episode. Let's see you all next week at the UroPatient Podcast.